by Lori Morgan with Judy Capco. Key insight: now more than ever, respect, attention, and tools are critical to customer service success. In 2010, for the second edition of this book, Judy wrote about how dramatically the role of receptionist had changed in the first decade of the new millennium. It would have been hard to believe at the time, but the pace of change at the medical practice front desk has only increased in the few years since. The most significant source of change is the rapid evolution of the insurance market in response to healthcare legislation and market pressures. Patients typically are responsible for a much bigger portion of the cost of their care than before, and they are often confused or surprised by the requirements of their plans. While the entire front office is affected by these changes, receptionists serve on the front lines. Paperwork needs have ballooned, and collecting money from patients at the time of service has become essential, and that has led to a steady creep of responsibilities added to the role of receptionist. As these new tasks have crept in, it's become harder for receptionists to stay focused on their primary role, the role that likely attracted them to the job in the first place, making patients feel welcome and cared for. What's more, when training can't keep pace with the rate of change in health plans or even the technology deployed in the practice, it's impossible for receptionists to feel that they are providing great service to patients. Morale suffers, and then so does the patient experience. Turnover may increase, and that means new receptionists with even less preparation take on the role. With such a vicious circle, it's no wonder that practice managers and physicians often despair of ever finding the perfect receptionist. But the perfect receptionist is out there, maybe already on your team, just needing the tools and encouragement to blossom. We know, we've seen it happen. The game has changed, but the complaints are the same. In the first and second editions of this book, Judy noted that managers and receptionists have long repeated the same set of gripes. 1. Receptionists have too many things to do and the load is constantly increasing. 2. Receptionists feel patients treat them unkindly or disrespectfully. 3. Receptionists want more help, more support, better training. 4. Managers are frustrated by patient complaints about receptionist efficiency and knowledge. 5. Managers are bothered by patient complaints that receptionists aren't attentive or sensitive enough. 5 years later, complaints 1-5 still top the frustration list on both sides, but a couple of new refrains have emerged. 6. Receptionists feel uncomfortable explaining financial terms to patients that they don't understand themselves. 7. Managers need receptionists to collect payments from patients more effectively. The complaints on both sides are still valid. So, what's the solution, and how can any practice hope to have a perfect receptionist? It starts by recognizing that the job of receptionist, often the lowest paid position in the practice, is no less important than any other staff position. Receptionists are the first people patients see in the practice. That interaction with patients sets the tone for the visit. The design of their role, the training they receive, and the technology at their disposal all affect their ability to deliver their very best customer service. Everyone still loves Susan. In 2010, in the second edition, Judy observed, "We all treasure the rare receptionist, the one that just loves her job and shows it. She's sensational. I know her, and her name is Susan. She enjoys every aspect of being a receptionist, and it shows." Susan was that energetic, positive, and efficient receptionist every practice wishes they had the perfect receptionist. She smiles, she's energetic, she's happy to see you, and she most obviously loves her job. Everyone loves Susan because she makes them feel important and she's a joy to be around, Judy wrote. And what made Susan so great at her job is because Susan knows she has an important job and has been given the tools to do it right. It's because she knows what her responsibilities are and what is expected of her. She takes pride in her job and what she accomplishes. One of the most interesting aspects of Susan's story was her approach to finding a new job when she relocated from California to the Midwest. Susan understood how the structure of her job would affect her ability to perform it. She declined numerous opportunities until she found one at the Heart Center that did not include handling incoming calls or scheduling appointments. When these activities are added to the job, as they too often are, it's impossible for the receptionist to give full attention to patients who are standing at the front desk. The worst part is that patients notice that the receptionist is distracted by multitasking, and they take it personally. The receptionist can feel patients' dissatisfaction, but can't do anything about it because her job requires her to try to do several things at once. No wonder morale at the front desk is often so low. The illusion of multitasking. How did the front desk evolve to include tasks like answering phones and scheduling appointments? Anyway, perhaps managers and physicians saw that receptionists have downtime when patients are waiting to be checked in. It's true that in almost any type of practice there will be times of day when fewer patients will be arriving or approaching the front desk to ask questions. For example, after the last patient arrives before the end of the day, or if an appointment is unexpectedly canceled. But is asking receptionists to multitask all day, juggling activities that are all equally urgent, the best way to fill that time? One challenge with juggling helping patients in person and answering phone calls is that it's almost certain that either the patient at the front desk or the patient on the phone will feel like a lower priority. One will be asked to hold on the phone, or the other will be asked to wait patiently while the receptionist finishes the call. If the receptionist is required to do both, the very design of the job undercuts customer service regardless how friendly or dedicated your receptionist is. As if this weren't bad enough, here's something even worse about multitasking. It's inefficient. Research shows that switching back and forth between two tasks is much less efficient than focusing on one thing and completing it before working on the next. Each time you switch tasks, your brain needs to reorient itself for the new priorities. That time you spend recalibrating is time that could instead have been used productively, and it adds up to a big productivity drain if you're switching constantly. David Mayer, PhD, a psychologist who has conducted several studies on multitasking, says that frequent switchers sacrifice as much as 40% of their daily productive time. Multitasking. Switching costs. American Psychological Association, Research in Action, March 20, 2006. Receptionists who try to provide in-person assistance while answering phone calls at the same time are more productive. They are just busier and more stressed, and probably also discouraged because they can't do either job as well as they like. Instead of relying on the front desk to answer phones, create a call team that can handle your inbound calls and scheduling. Staff both of these functions at the right level, and you'll handle all of these tasks more efficiently and with better service. And if receptionists have too much downtime, utilize their free moments with non-urgent tasks like marketing projects that they can easily abandon when a patient needs help. Technology, more important than ever. When Judy last checked in with Susan, her practice was newly wired. They had started using their electronic health record EHR for checking in patients, so back office staff could be alerted immediately when a patient was ready to be roomed. And if a doctor was running behind, Susan could check the EHR to see how many patients were already roomed and waiting, and how far along the doctor and the nurses were in working. Through the queue, when Susan decided to join the Heart Center, their use of technology was another selling point for her. She knew from talking with colleagues at other practices that an EHR can be a godsend for patient service in the front office if everyone uses it properly, and a source of confusion and misinformation if they don't. Technology enabled teamwork. Susan was able to rely on the EHR for up-to-date patient flow information because the front office and the back office work together to update the system in real time. This allows everyone in the practice to benefit from accurate information about the day's progress. This consistent tracking also allows management to review the data, study flow bottlenecks, and improve efficiency. Practices that don't understand how entering this data can actually save a lot of time typically either don't use those fields at all, or they take shortcuts that make the data much less useful. Some practices have their receptionists check patients in to alert the back office that they've arrived, but then the back office team never updates patients' progress through their visit by indicating if they're room, with doctor, etc. Or, they may have their MAs update the system to show checked out after the patient is seen, but they won't know when the patient is roomed or when the doctor enters the room. Nurses may believe it's more efficient to wait and update all the patients as checked out at the end of the morning or afternoon clinic, so the system incorrectly states that everyone left at the same time. Because these small data entry tasks require thinking differently about workflows, sometimes changing processes that were in place for decades, it's easy to see how there might be some resistance, and it's easy to see how entering data might seem like more work. So how can it be more efficient? What if your receptionist is able to look at the system just 1 or 2 times a day to get needed information, rather than interrupting an MA and disrupting flow in the back office? That would certainly save more time and effort than a few keystrokes in the EHR requires. And for most practices, having up-to-date information about patient flow in the system will eliminate many more than 1 or 2 daily interruptions. Making sure the entire team understands the value that's created by this small effort will help encourage them to comply. When Susan does need to interrupt one of her colleagues for an urgent matter, technology helps with that, too. The EHR's instant message system allows Susan to quickly send a question or request, then get back to helping patients. Her colleague, in turn, can finish up with the patient, then quickly respond to Susan. Everyone can stay focused on the task at hand, yet provide quick assistance without breaking flow. New financial challenges, new technologies. Susan also appreciated how the Heart Center had been an early adopter of kiosk technology to allow patients to check themselves in and even make payments. In 2010, more than 35% of the Heart Center's patients were using the system. Even many of their most elderly patients embraced the system, many of them having grown to love using the internet to stay in touch with family and friends, keep tabs on their money, and shop without having to leave the house. By getting an early jump on deploying kiosks, the Heart Center empowered Susan and her colleagues to better contend with the significant changes to receptionist workflow prompted by high deductible plans and healthcare reform. Building on its success with the kiosks, the Heart Center added tablets to its mix of check-in technologies. New patients can use them to enter their demographic and chief complaint information. Patients value the privacy of entering data directly, instead of having to write it on a paper document that will circulate through the office. And patients who owe balances or have deductible or co-insurance due are reassured that the figures are correct, because the tablet connects directly to their health plan. A receptionist no longer needs to guesstimate their payment. If a large amount is due, patients can even establish a payment plan right on the tablet, silently and privately, so no one else in the reception area overhears anything about their balance. These features help the receptionists at the Heart Center project confidence when answering patients' financial questions. Your payment information is all available to you in the tablet system, Mrs. Peterson. This allows them to focus on checking patients and then helping them with other tasks, such as handling occasional cash payments, setting up patient portal accounts, and answering questions about other forms which, of course, can be read and signed easily via the tablet. Collecting payments effectively at the time of service is essential to practice profitability. Research shows that amounts not collected at the time of service are less likely to ever be paid, and the cost of collecting them is high. Front desk employees need to be able to confidently provide patients with financial details and collect amounts due without involving billing staff or otherwise interrupting the patient's flow through the practice for their visit. A system such as a tablet or kiosk is invaluable because it allows patients to easily look up and pay their portion of the cost of services with confidence that the figures are right and that their privacy is protected. Self-service technologies that make tasks like check-in and payment easier and more private provide clear benefits to patients. But even so, training patients to use them and change their habits requires focused effort. The Heart Center learned this originally with their kiosks. Rolling out a new self-service technology always requires patience, commitment, and planning. Whether you're adding a patient portal or a check-in solution, you may need to train patients multiple times before they'll be comfortable with the switch. Staff needs to understand that adoption will be gradual, so that no one gets discouraged or is tempted to give up. Staff also needs a clear understanding of their role in helping the patient adapt to new technology. Moreover, as the Heart Center learned, patients of any age are happy to learn how to use new technologies that benefit them. Virtually any type of practice can benefit from launching more self-service options. Each new patient who learns how to use these tools gains more convenience for himself and frees up time for staff to do other important tasks. Even when it takes longer to get patients used to the switch, sticking with it can bring a substantial long-term payoff for patients and the practice alike. Some practices may find that EHR or practice management system PMS doesn't integrate with currently available kiosk or tablet technology. Fortunately, with lots of competition in a growing market, there are excellent standalone software tools for online estimation of patient responsibility payments and online verification of insurance eligibility across virtually every insurance plan. Even if you have a kiosk or tablet system in place, adding one of these online verification and estimation dashboards to your practice may allow your entire front office to easily check this information on behalf of a patient if necessary. So, for example, schedulers can help alert patients to past due balances or the expected out-of-pocket cost of an upcoming service, workload, and productivity. As front office technology continues to improve, practices that deploy it quickly will be the first to scale the learning curve and stand to reap the most benefits. It can be daunting at first, especially if your practice has felt burned by, for example, a complex EHR or PMS implementation that didn't go as planned. But unlike those foundational systems, front office tools for eligibility checking, out-of-pocket estimation, and electronic patient payments are almost always easy to implement and flexible. They are intended to perform a smaller number of focused tasks well, not handle every practice management or medical record task like PMS and EHR systems must, by definition, be able to do. This means these new products are less risky to implement and typically much less costly, too. In fact, the business model is often similar to the credit card processors they replace in your practice, sometimes with an additional monthly license fee. There's plentiful research data available that consumers prefer online payment solutions, and especially self-service solutions that allow them to perform transactions on their own time or on their preferred devices, or both. Early experience at practices like the Heart Center bears this out. As practices deploy these solutions, they allow their receptionists freedom to provide excellent, welcoming service, while also ensuring that patient payments are reliably captured at the front desk. They also enhance the patient payment experience by allowing them more control and flexibility. What's not to love? Over time, as practices automate, they will find that they can happily keep staff focused on jobs that can only be done well with a human touch. There are still many aspects of navigating the healthcare system that your patients need a helping hand with, whether it's a referral to a specialist, assistance adding a loved one to a portal account, or help understanding the scheduling and payment processes at the hospital where they'll be having a procedure. With compassionate and knowledgeable people ready to help when only real humans will do, your practice will help patients become more engaged and, hopefully, more compliant with their care plans. And what if technology works so well that you wonder if you need fewer staff? At the Heart Center, the receptionists have used their downtime to help with ad hoc marketing projects. The time-consuming job of monitoring and updating physician rating sites and health insurance directories is one excellent way to use unpredictable free time that most practices can adopt. This not only saves money versus outsourcing, it also puts the task into the hands of staff members who will likely do it better and more quickly than a consultant or contractor. These tasks are just one example of how a practice can use receptionist downtime without compromising patient service. If a patient comes to the reception desk, marketing tasks can be put aside immediately. After her long and successful patient service career, Susan plans to retire from the Heart Center within a year, and her manager may decide not to replace her, since technology has helped the team be more efficient. But the manager will move slowly, ensuring the practice retains the human touch Susan and the rest of the reception team provide, which has been integral to the practice's philosophy of attended patient-centered care. Branding at reception. Should your receptionists be called PSRS patient service representatives, or some other name that encompasses service and maybe has a more modern zip, too? When patients come to the reception desk and see your staff with clean, bright name tags, they may also be pleased to see a title that puts them first. If you're aiming to make patient service the top priority of your receptionists, and by now you must know that we think you should, it makes sense to spell it right out in their titles. Both the title and the tag that displays it are part of your reception branding. A friendly, confident person whose job it is to help patients, with a job title that reflects that, is the best way your practice can create an excellent first impression. The secrets. 1. Recognize the importance of the receptionist and the skills required to do the job right. 2. Simplify and clarify the position. Create a call center/scheduling team to handle inbound calls and set appointments. 3. Encourage receptionists and back office staff to use workflow and messaging tools to cut down on interruptions that sap efficiency. 4. Add technology that helps patients serve themselves and understand and meet their financial responsibilities. 5. Monitor workload volumes and demands. Be ready to staff up if needed. Be cautious and monitor service carefully when reducing receptionist staff. 6. Assign appropriate non-urgent tasks to utilize receptionist downtime without sacrificing patient service. Forms added to your toolbox. See alphanumerical accuracy quiz. Sample EHR project timeline schematic. Sample job description receptionist. Sample performance standards worksheet. Chapter 4. Conquering Workflow Problems by Judy Katko. Key insight. Centralize and assign tasks sensibly to reduce frustration, smooth workflow, and increase patient satisfaction. W. You need help. Our receptionists are drowning and the patients are outraged. Mark Schroeder, the administrator of West End Orthopedics, a 6-physician practice in the Midwest, pleaded. In this practice, some of the biggest problems seemed to begin when patients arrived at the office for their appointment. For starters, it was taking too long to check patients in and out. This resulted in physicians getting behind schedule, which wreaked havoc during the clinic sessions and led to patients being disgruntled with the long delays. The receptionists didn't have time to verify patient demographics or insurance, and they certainly weren't going to ask already angry patients for money. The receptionists and nurses never felt caught up and they were frustrated. So were the doctors. The problems were maddening for everyone, and emotions were running high. On our initial visit to this practice, we saw the problems firsthand. 4 doctors were scheduled to see patients, and there were 4 lines of patients waiting to check in. As I approached the desk, I discovered each of the 4 receptionists was wearing a phone headset, making it impossible for patients to know if the receptionist was on the phone or prepared to assist them. The check-in process was complicated, inconsistent, and moving at a snail's pace. What was wrong? Each of the 6 physicians had his own check-in station, managed by his receptionist. Most of the physicians felt their receptionist was the only one who knew their patients, understood what was needed, and had the skills to properly manage the appointment schedule. Therefore, their assigned receptionist was the only one trusted to check in patients, schedule telephone appointments, check out patients, and schedule follow-up appointments. Nonetheless, the current system was failing both patients and staff. The receptionists also were responsible for all inbound appointment phone calls for their assigned doctor, which sabotaged their ability to give patients the attention they needed and deserved. Each receptionist had 3 choices. 1. Ignore callers by placing them on hold. 2. Let the call go to voicemail, not knowing when they would have time to listen to the calls, let alone return them. Or 3. Ignore the patient checking in to deal with callers and schedule the appointments. When phone calls went to voicemail, they would linger there for hours before the receptionist found time to retrieve them. Patients calling for appointments would hang up in frustration or leave curt messages, and were forced to keep calling back. The incoming calls were multiplying like rabbits in spring, and patient satisfaction was plummeting. A patient bottleneck at checkout was exacerbated by what was happening back in the clinic. Patients who had already seen the doctor stood waiting for the nurse who was wrestling with documentation or talking on the phone. These patients were delayed because nurses were taking clinical calls from other patients, insurance carriers, and other physicians. In between these calls, the nurses would be calling diagnostic centers to schedule patients for tests. They were bogged down with phone calls and paperwork that hampered patient flow, keeping patients longer in the back office and slowing their move to the checkout counter. As if this wasn't enough, the nurses were even completing disability forms and dealing with workers' compensation adjusters who needed updates on patient statuses. The practice habitually ran late with anxious patients waiting for their turn. No wonder staff turnover was rampant and disgruntled patients were speaking out. The challenge: we had seen similar situations before. Too many people were doing the same thing. Centralizing some of these tasks would dramatically improve efficiency, workflow, and patient service. The first step would be to gather data to clarify how serious the problem was and identify underlying factors that needed to be addressed. Collecting the data would be time-consuming, but not difficult. The biggest challenge we anticipated was convincing the physicians to change a system that was familiar and comfortable for each of them. We knew getting the physicians to approve a change would take nothing short of a miracle. These orthopedic surgeons had the Migros syndrome. They couldn't imagine anyone but their own nurse and receptionist helping them or their patients. Convincing them to centralize processes and rely on other staff members to meet their needs would be a hard sell. So we began building our case. The power of data. Data taught they are tangible evidence that helps define problems, predict results, and influence the decision-making process. Data should be the foundation for planning and negotiation. Before we could get physician buy-in to change the ways things were being done, we needed to complete a data analysis that would describe the extent of the problem and the value of redistributing the work more efficiently. A committee composed of a receptionist, a nurse, and the clinical supervisor, headed by the practice administrator, assisted with the project. This core group would be invaluable in convincing staff and doctors of the need for change. The committee met to discuss the extent of the problem and the best way to collect sound data. Our goal was to examine and refine processes to create a lean machine. This would mean exploring which processes brought little or no value to the organization, identifying redundant steps that could be eliminated, and refining the remaining processes in a meaningful way. First, we turned to the systems. A report on the number of new and established patients seen in the office was pulled from the practice management system PMS. The scheduling system's templates showed us the appointment slots reserved for the various appointment types for each physician. The telephone system generated a report providing call information for every phone, how many total calls were coming in, how long each call took, and how many calls were abandoned. But the report didn't tell us the nature of the calls, nor did it separate inbound calls that were answered from those that went to voicemail. So, we conducted a patient visit time study. A sample is included in the toolbox, timing the length it took to schedule 10 separate new patient appointments and 10 separate established patient appointments when not interrupted. We also documented how often the receptionists were on the telephone when a patient arrived. The nurses and receptionists were called on to help us collect data from each point of service, the moments of truth. These detailed data about the types and volume of various activities allow for a comprehensive view of the overall workflow problem. A sample is included in the toolbox. The data collected included number of incoming appointment calls, separating new and established patients, average time for a nurse to complete a patient visit if uninterrupted, number of phone calls for the receptionist and nurses going to voicemail, and number of abandoned calls. Each receptionist was enlisted to document the volume of appointment telephone calls received over a 1-week period, including those that went to voicemail. A sample is included in the toolbox. Most of the receptionists saw the light at the end of the tunnel and were more than willing to lend a helping hand. They understood that we wanted to make their job easier. The information collected would enable us to calculate the volume of calls, determine peak hours, and examine the various call patterns for each physician. We anticipated and observed variations based on their individual practice style and patient mix. One problem we discovered was the barrage of incoming calls when staff returned from lunch. The practice shut down the phones during lunch break at the most convenient time for many patients to call for appointments. The unmet demand of patients calling during this time resulted in many voicemails that had to be returned and some unhappy patients calling back in the afternoon. An unknown factor was how many potential new patients may have called during this time, given up, and scheduled with another practice, lost forever. This was a separate issue, but a good solution to the overall phone problems had the potential to influence better conversion of prospective new patients. The next step depended on the nurses. A patient visit time study was essential to understand workflow throughout the patient visit. We needed to know how much time was lost during a patient visit and why. Each receptionist and nurse tracked visits for their physician for 3 days. They completed a patient visit time study form for every third patient, documenting exact times as the patient flowed through each process, from check-in to check-out. This gave us reliable data and helped us understand how existing workflow processes interacted and affected each other. Practices with EHRs that have timestamp features can replicate this process more easily by training front and back office staff to make sure stamps are accurately updated for every patient. We gathered additional data through interviews and by observing this busy orthopedic practice for several days. The observations were very telling. Frustrations mounted through the day, and a series of various types of interruptions and activities hampered workflow and consumed time for nurses and receptionists. The findings. Armed with these data, the analysis began. The investigation provided both predictable and startling results. The demand was pinpointed and workflow processes were clarified. The receptionists each handled an average of 39 incoming appointment calls a day, with a low of 22 and high of 56 on a single day. When tracking time, those calls that went to voicemail VM required an additional 1.5 minutes to retrieve the message and return the call. 33 established patients. Direct, 20 calls at 3 minutes each. VM, 13 calls at 4.5 minutes each. 6 new patients. Direct, 4 calls at 8 minutes each. VM, 2 calls at 9.5 minutes each. 65% of the telephone requests for appointments occurred between the hours of 9 a.m. and noon. Abandoned calls spiked between 12:15 p.m. and 2 p.m., accounting for 37% of the total calls received during this time. Monday and Friday mornings reported the highest call volume. 80% of the patients arrived within 5 minutes of their scheduled appointment. Check-in for an established patient was taking an average of 6 minutes. New patient check-in required 9.5 minutes. The receptionist was free from the phones to greet patients on arrival only 25% of the time. Patients were roamed as early as 5 minutes or as long as 52 minutes following completion of the check-in process. On average, the lag was 26 minutes. The peak times for bottlenecks in the front office were directly related to the peak time for incoming phone calls and were most severe between 10:30 a.m. and noon, and again between 2 p.m. and 2:30 p.m. The peak times for bottlenecks in the clinical setting were in the late morning and again around 4:30 p.m. Physicians arrived in the exam room an average of 33 minutes after the appointment time for established patients and 39 minutes for new patients. The time to schedule outside tests delayed patient checkout by 5 minutes, but created a secondary delay as the nurse was detained from rooming another patient. The time span between the conclusion of the doctor's visit and completing in-house studies was 45 minutes. Many times, patients were held up in the subwait station, as staff conducting the diagnostic studies got backed up. Scheduling templates showed that often 2 or 3 physicians would be seeing new patients at the same time, creating a backlog with X-ray and ultrasound. When patients came out of the exam room, 1 out of 3 waited for assistance in scheduling studies while the nurse finished a phone call. Each nurse had a daily average of 9 calls from workers' compensation insurance adjusters. Each nurse scheduled an average of 11 outpatient diagnostic studies each day. 8 of these required pre-authorization. On average, 18 patients were seen for each morning session and 21 for each afternoon session. This meant each receptionist was checking in and out an average of 39 patients, and 6 of these were new. The patient checkout process averaged 6.5 minutes. Our investigation indicated that it would require 2 full-time schedulers to manage the volume of telephone appointments once dedicated schedulers were in place. We also thought that West End Orthopedics website should be enhanced so that new patients could pre-register online and existing patients could schedule their own appointments. These website enhancements would considerably reduce the call volume for the schedulers. Because they would be relieved of telephone scheduling, the receptionists would have an additional 2.5 hours each day to dedicate to receiving and processing patients during clinic sessions. We knew this would result in a far better patient experience and ensure patients flow through the system with much greater efficiency. This added time would allow the receptionist to adequately review patient demographics and update and re-verify insurance information. On the checkout side, retraining would be provided on collecting patient payments and setting up payment plans. Setting scheduling rules to ensure that multiple physicians weren't seeing new patients at the same time would level out the demand for in-house diagnostic studies and help further improve patient flow in the clinic. Combined with freeing nurses from clerical tasks, this would keep the sessions moving and open up additional time. Nurses could then be assigned the responsibility of auditing each patient's charges to ensure no charges were dropped and diagnoses were recorded. The remedy. With data in hand, the solutions were clear. If the workload was redistributed through task-related centralization, the majority of the existing flow problems could be solved. The staff could ensure charges were captured, payments were made, and demographics were updated. With proper training and clear expectations, greater efficiency and profitability could be expected. The preliminary action plan was crafted. 1. Remove phones from the front desk receptionists and centralize. 8. Assign 2 receptionists to be full-time schedulers and relocate them to a separate, quieter location that would become the call center. This location would be closer to the clinical area. B. The 4 remaining receptionists would be responsible for all of the 6 physicians when they were in session. This would not be difficult, as there were never more than 4 physicians in session simultaneously, and 50% of the time only 3 physicians were in session at one time. 2. Keep the call center open during the lunch hours. 3. Eliminate nurses obtaining insurance authorization and scheduling outside diagnostic studies. When the 4th receptionist was not responsible for a clinic session, she would obtain insurance authorizations and schedule all the outside diagnostic studies that had been ordered. 4. Reassign completion of disability and workers' compensation return to work forms to medical records staff. Begin research on the potential to automate these processes using the EHR. Train staff appropriately for the new tasks to be assumed. 5. Establish daily collection goals for patient payments. 6. Change the physician scheduling templates to stagger new patient visits. Because each physician's receptionist was near and dear to his heart, we knew that getting support for change would be more than a little difficult. Support from the top was essential. The key was getting one physician to endorse the new workflow model and change in staffing responsibilities. Past experience predicted that if we succeeded with converting one physician, a commitment from the other physicians would soon follow. Searching for a champion. Our first charge was to identify the doctor that would champion our cause and be willing to lead the pack. One physician, Arthur James, MD, stood out. He was the most forward-thinking and decisive of the group. He was also influential with the other physicians. At a meeting to present the data to the remaining physicians and solicit their support, Dr. James played a key role in gaining their confidence and impressing them with the expected gains that could be achieved. He was a master at overcoming objections and obtaining consensus. When the evidence was laid out and the plan was presented, the doctors quickly saw the advantages. They knew there was a solid rationale behind our recommendations, but still feared an overall loss of control. We explained that they could set up their own protocols for scheduling. The doctors could also have input as we developed the training modules for scheduling. A meeting with each physician and the scheduler would take place before the switch was made, and the transition would be unhurried and methodical. Morning huddles with involved staff would begin as soon as the program was launched. Regular meetings would be scheduled during the first 90 days to make sure each physician's needs were being met and problems were quickly solved. Convinced the plan was sound, the doctors approved our plan and we put it in motion, making IT happen. The committee had a lot of planning to accomplish before the transition could begin. The schedulers were added to our committee to solidify their commitment, help us finalize the plan, and assist with a smooth transition. The pre-launch planning took on a life of its own. We headed this effort with the assistance of the administrator and the support of the planning committee. There were planning meetings and interviews, flow charts, training guides, and phone scripts were developed. Job descriptions were revised and implemented. There were practice sessions and more meetings. We anticipated some resistance, but with the support of their peers that served on the committee, most of the employees accepted our plan with little resistance. During the planning phase, we continued to monitor the number and length of telephone calls and measure the scheduling demands against the capacity of the two schedulers. We needed to follow our progress, know the staffing needs, and make any necessary adjustments during the transition. At last, the detailed action plan was ready for implementation. Because the committee members had been actively involved in the development of the model, they were enthusiastic and influential in bringing the remaining staff on board. It didn't take much for staff to visualize how the new workflow model would improve their life on the job, creating a better work environment and manageable workload. The crowning glory would be an end to patient dissatisfaction. They were about to see all of this become a reality. Some adjustments needed to be made during the first few weeks, and quite a bit of handholding was required. There were morning huddles with physicians, receptionists, nurses, and schedulers, during which they discussed issues from the previous day, reviewed the daily schedule, and prepared for any potential problems. At the end of 2 weeks, the physicians and staff members involved in the process met with the committee to review their progress and discuss any suggested modifications to the plan. In general, everything was on track and moving forward, reaping the rewards. Within 60 days of launching the new workflow model, staff and physicians were touting its success. Patients were roomed on time and the work was flowing. There was no grumbling from patients or staff. Communication was greatly improved. There were fewer interruptions and no disruptions. The real bonus was getting out of the office on time. One would be hard-pressed to argue with this type of success. When it comes to patient care and related workflow, West End Orthopedics is ticking like a fine Swiss clock. The fog of confusion and chaos has disappeared, replaced by a streamlined system that meets the needs of physicians, staff, and patients. The receptionist's productivity has skyrocketed. They now have plenty of time to input new patient demographics and update records for existing patients. The benefits are seen in the billing department as rejected claims have diminished, improving cash flow. At the same time, cash flow has been given an additional boost because the receptionists are now collecting effectively from patients. In fact, patient payments increased by 100% within 6 months. The nurses are able to assist their patients as they come out of the exam room. Forms and documentation are processed quicker and patient care is timely. Schedulers are making appointments the first time around. They have mastered the process. They have time to pre-register the patient properly and with more detail. Errors in pre-registration and insurance verification have dropped dramatically. Bottlenecks and patient complaints are a thing of the past. As an added bonus, the new workflow model has done a lot for team building. The employees now depend on each other to get the job done and care for the patients. Morale has never been better, adapting to change. Since the introduction of the Affordable Care Act in 2010, there has been a national push to measure outcomes and improve the quality of patient care and service. This has resulted in a move by third-party payers to financially reward physicians based on performance and clinical outcomes. It began with CMS, but other payers have implemented bonus payments based on these factors. West End Orthopedics began to focus on improving the patient's overall experience, and in service on making patients feel important was presented. All staff and physicians were required to participate. Everyone learned some easy ways to engage patients and improve the patient experience. During the in-service, the team committed to the following standards, which are monitored through patient surveys. 1. Each person will introduce himself or herself on the phone and also when interacting with new patients. 2. When rooming patients, the nurse will A. Ask if there is anything they can do to make the patient more comfortable. B. Communicate what the patient can expect next. C. Estimate wait before the physician will come in. 3. Each visit will end with asking the patient if there is anything else the practice can do for the patient. Following the in-service, a brainstorming session took place with the administrator and the reception team. They participated in identifying a set of customer service standards requiring them to give patients their full attention. They were also given the new job title of reception ambassador, placing emphasis on their new patient service responsibilities. Their job description was revised, outlining these additional responsibilities. It also resulted in a review of their pay scale and an adjustment in their pay rate based on these added responsibilities. The practice has also fine-tuned the referral process by adding a new position, patient referral coordinator. This person manages all referrals and keeps communication flowing between the referring office and the patient, as well as managing the reporting processes, coordinating insurance coverage, and managing the financial payment plans with patients. This has improved coordination of care and patient service. The practice is exploring the requirements to achieve the designation of a patient-centered specialty practice PCSP through the National Committee for Quality Assurance www.ncqa.com. The secrets. 1. When complaints are chronic, they signal workflow problems that must be addressed. 2. Centralizing functions can help streamline processes. 3. Call centers minimize front office interruptions. 4. Keep telephone lines open during the lunch hour. 5. Remove clerical tasks from nursing staff. 6. Centralizing doesn't necessitate additional staff. 7. Patient flow problems reduce productivity. 8. Centralization improves teamwork. 9. Make patient service a top priority. 10. When an administrator and consultant team up, the results can be amazing. Forms added to your toolbox. Clinical telephone tracking incoming calls. On-site